We are starting with slide number 33, and this is from slides 18B. And this is also the beginning of section 18.6, the mechanical events of the heart. A few terms that you need to make sure that you're familiar with is systole, which means heart contraction, diastole, heart relaxation, and the cardiac cycle, which is defined as blood flow through the heart during one complete heartbeat. So the cardiac cycle is referring to what happens during one complete heartbeat, which if you've ever listened to a heart with a stethoscope is just that lub-dub, lub-dub. Lub-dub is considered one complete heartbeat. Now, during the cardiac cycle, atrial systole and diastole, that means atrial contraction and relaxation, are followed by ventricular systole and diastole. So ventricular contraction and relaxation. The cycle represents a series of pressure and blood volume changes, and the cardiac cycle consists of mechanical events following the electrical events seen on the EKG. There are three phases. And they are ventricular filling, isovolumetric contraction, and isovolumetric relaxation. So during ventricular filling, we call this mid to late diastole. The pressure is low. 80% of the blood flows from the atria through the AV valves into the ventricles. The AV valves are open and the semilunar valves are closed during this event. And it's gravity, really, that's causing the blood to flow from the atria into the ventricles. Then you have atrial depolarization starting with the SA node, and that triggers atrial systole or contraction, and that pushes the remaining 20% of blood into the ventricle. A measurement called the end diastolic volume, or EDV, is the volume of blood in each ventricle at the end of ventricular diastole or ventricular relaxation. So at the end of this ventricular filling stage, the amount of blood is called the EDV. Now, the depolarization spreads to the ventricles, which is shown as a QRS wave, and the atria finish contracting and return to diastole while the ventricles begin systole. So ventricular filling is literally goes from the mid to the end of the relaxation stage of the ventricles. As soon as the ventricles begin to contract, that marks the beginning of the second event, which is isovolumetric contraction. Anytime you have isovolumetric, all the valves are closed. That means the AV valves and the semilunar valves are closed, and it doesn't last long. During this isovolumetric contraction, the ventricles begin to contract, but it's right before they actually push the semilunar valves open so that the blood can flow into the major arteries, the aorta and the pulmonary trunk. Once the ventricular pressure exceeds the pressure in the large arteries, the aorta and the pulmonary trunk, and the semilunar valves are forced open, that ends this stage. That ends the isovolumetric contraction. And then you have isovolumetric relaxation, or early diastole, and that follows ventricular repolarization. The ventricles relax, and the end systolic volume is the ESV, is the volume of blood remaining in each ventricle after systole or contraction. So there's going to be some blood that doesn't get pumped out of the heart, a little bit that remains. And for this momentary event, isovolumetric relaxation, all the valves are closed. And that occurs until the pressure in the atria becomes higher than the ventricles and the AV valves open. So let's see, the dicrotic notch is when the closure of the aortic valve raises the aortic pressure as backflow rebounds off the closed valve cusp. It's called the dicrotic notch. So the cycle ends as the AV valves open and a new cycle begins. Heartbeats are on average around 75 beats per minute. And this is just showing you the stages. I'm just looking to see if there's anything I want to go over with you. I mean, mainly just kind of compare your pictures at the bottom to the graphs. There's a graph of ventricular volume, and then there's a graph showing pressure. And you can see the pressure in the aorta versus the left ventricle versus the left atrium. And that all of that related to the volume of blood in the ventricle. So during ventricular filling, you can see during the ventricular filling phase that the AV valves are open, that the semilunar valves are closed. And then there's the isovolumetric contraction phase. Okay, I knew there was a mistake. Look at this. Okay, so let's go back. I knew that couldn't be right. All right, after the isovolumetric contraction phase is ventricular ejection. So this should be 4. The isovolumetric relaxation should be step 4. And then step 3 should be ventricular ejection. You know what? Just because I know how my time is looking, I'm going to fix this on here. So this is going to be ventricular ejection. And here, okay, here's what we're going to do. We're going to copy this one. Copy slide, but we are going to name this 4 instead of, and I know that's not blue, but it'll be okay. And then here we are going to call this ventricular ejection is step 3. And I'm not going to do a lot as far as notes, but I do want you to know that during ventricular ejection, the AV valves are closed and the semilunar valves are open. Okay, and let's just leave it like that. I apologize for that mistake, but let's go ahead and move on. Okay, now okay, so during ventricular ejection, again, the semilunar valves are open, but the AV valves are closed. And then during the isovolumetric relaxation, all the valves are closed again. And during isovolumetric relaxation, there's only a small amount of blood in the heart chambers. But during isovolumetric contraction, the ventricles are filled with blood. But both of those isovolumetric stages, all 4 of the valves are closed. All right, for the heart sounds, the heart makes 2 sounds, lub and dup. And the lub is a harder, louder sound. It's the first heart sound, and it occurs because the AV valves close. And the second sound is when the semilunar valves close. And then the pause between the 2 lub dups is when the heart is relaxed. Okay. And then we have, for our clinical notes, we have heart murmurs are abnormal heart sounds heard when blood hits obstructions. They usually indicate valve problems, either incompetent or insufficient valves, which fail to close completely, and they allow backflow of blood. What we hear is a heart murmur. We hear a swishing sound as the blood regurgitates backward from the ventricle into the atria. You can also have a stenotic valve, which fails to open completely, and that restricts blood flow through the valve. That will cause a high-pitched sound or clicking as blood is forced through a narrow valve. Some measurements that we take to determine heart health or heart function is cardiac output, which is the heart rate or beats per minute times the stroke volume. The stroke volume is the volume of blood pumped by one ventricle with each beat. And the stroke volume is going to correlate with the force of contraction. So it'll be a larger volume with when the force of contraction is greater. Now, at rest, the cardiac output is equal to 75 beats per minute heart rate, 70 milliliters per beat stroke volume, and that corresponds to a little over 5 liters per minute pumped. Okay. The factors involved in determining cardiac output are shown on this slide. Basically, your cardiac output is your stroke volume times your heart rate. So stroke volume can be increased by increasing venous return, which is the amount of blood that returns to the heart by the vena cava and the coronary sinus. That's going to increase the end diastolic volume, which we also call the preload. So the greater the end diastolic volume, the greater the stroke volume. The greater the contractility of the heart, that is going to decrease the end systolic volume, or the amount left in the heart after it contracts. And that will increase the stroke volume, which will increase cardiac output. So what are some things that can increase stroke volume? Exercise, ventricular filling time due to a decreased heart rate, and epinephrine, the hormone epinephrine or norepinephrine, thyroxine, and excess calcium can increase the contractility of the heart. So these can all increase stroke volume. Then changes in autonomic nervous system output in response to exercise, fright, anxiety, or lowered blood pressure. So when sympathetic activity increases, that will increase the heart rate. When parasympathetic activity decreases, that will increase the heart rate. And increasing the heart rate will increase cardiac output. All right, normal stroke volume is about 70 milliliters per beat, and that equals the end diastolic volume, subtract the end systolic volume. So about 70 milliliters per beat. There are three main factors that affect stroke volume. That is preload, or EDV, contractility, and afterload, or ESV. Preload is the degree of stretch of the heart muscle, the degree to which the cardiac muscles are stretched just before they contract. And preload affects the end diastolic volume. The relationship between preload and stroke volume is called the Frank-Starling law of the heart. The most important factor in preload and EDV is venous return, the amount of blood returning to the heart from the vena cava. Increased venous return distends or stretches the ventricles, and that increases the force with which they contract. Contractility, independent of the venous return and the EDV. So increased contractility occurs by sympathetic stimulation by the hormone epinephrine, increased calcium, Positive inotropic agents like thyroxine, glucagon, epinephrine, digitalis, high extracellular calcium, and what will decrease contractility is negative inotropic agents like acidosis, increased extracellular potassium, and calcium channel blockers. I remember my daughter when she went into DKA. She's got type 1 diabetes, and DKA is diabetic ketoacidosis. And I remember her breathing and her heart rate and thinking she was going to die, literally in my arms when she was 2. But so I can personally relate to that acidosis decreasing the contractility of the heart. It was like I couldn't really hear, her heartbeat and all, and I was afraid it was going to stop. Okay, and we will start on this slide that talks about afterload, which is the pressure that the ventricles must overcome to eject blood. And it results in increasing afterload results in increased end systolic volume and decreased stroke volume. So actually, let's move on okay, so this is a good one to start with, is the regulating the heart rate by the autonomic nervous system, chemicals, and other factors.